All right, team models and current issues within the physical therapy world. I've seen some of the discussion board homework, and we'll talk about that again. That's due next week, but I've seen some. We've given a lot of time to do that. So, test. Everything's working. So we've given some time with it. I like a lot of the brochures. So your job, I know a lot of discussion board comments make you reply. I'm not making you reply. That's not part of how this class is designed, but definitely look at some of the brochures. There's some really cool fields that people have brought out. There's a couple I want to talk about that I didn't put in this PowerPoint. Who did the respiratory therapist one? Yeah, you did a great job with that, and that's a really cool field. And CCRI also offers a respiratory therapy program. So pretty cool. So, but definitely check out other people's work and just get an idea of all the different types of professions. I'm always amazed at the different professions in healthcare. And I always hear of a new one that I've never heard before, and they also pay really well. And it's like, geez, I can't believe that's what you get paid for that, like small, narrow field of what you do. So, anyway, let's talk more about that. So, broad objectives. So healthcare is performed in a team. And by definition, the PTA has at least two other members of the team. First of all, the patient, like that's the most important member of the team. And then the PT is the next one. So at minimum, you're on a team. There are other members of the team that patients are typically going to have: family members, primary care docs, specialist docs, a lot of other people to consider. Maybe their own kids are members of the team. Maybe they can or can't help us, but they're an important factor for us to think about. So other parts of the medical team depends on the setting that we're working in. Hospitals, lots of different people with really narrow scope of what they get to do. Versus outpatient, there's a lot smaller of a medical team generally. We'll look at some of the difference for that. But it's really important to know all of the roles, at least broadly, at least have a working knowledge of it. Because one, we want to communicate effectively. We want to be able to give valuable information. We want to receive valuable information. If we have a problem with our patient, we need to know who to ask. Hey, I saw this with this person. What do you think? To ask questions, give referrals. Oh, that person's definitely, they didn't have these speech deficits when we first looked at it, or somebody overlooked this. We definitely need speech now. So knowing who to refer, what part of the team we need to bring in is the other part of that. And then the other, maximize our visits and improve our outcomes. Our patients want to get better faster. And there are plenty of times where patient had a horrific injury or some sort of new diagnosis, and the ones I can think of that make the most sense for this example are stroke. Someone had a big stroke, they were walking around yesterday, and now all of a sudden they can't get out of bed. Sometimes what I love to do is I get to co-treat with PT and OT to work on different tasks. So as I'm working on the standing part and the standing balance, that I'm holding the patient, and the OT is working on reaching to the cupboard, grabbing the toothbrush and toothpaste to coordinate that activity. So that's a really valuable co-treat where we're all getting something out of it. And what is the patient doing during that time? They are working their tails off on a lot of different things at once. So that's a way we can maximize our visits. And then the other thing that between the patient getting a lot of work done at once, I get to collaborate with my other colleagues to say, like, all right, what else can we do for this person? Oh, have you ever heard of this modification? No. Have you heard of this exercise? Okay, great. And I've had a few patients post-stroke that their physical functioning, they're walking around great, they're getting out of bed, no problem, they're ready to go home physically, but their speech is really delayed and they're not going home for 2 more days. All right, so their speech is the biggest problem. I'm still going to do PT because they're not getting discharged for 2 more days. Hey, speech therapist, what are the things you're doing that I can incorporate into my treatment? I can work on standing balance as we do these flashcards, and they have to say the thing on the flashcards. Great. I definitely can do that. It doesn't take away from my treatment, amplifies yours. Love it. So that's the way a healthcare team really works well with one another. And it's crucial for our patients. I also get way more job satisfaction when I get to work in a cohesive team rather than just doing my job. Anybody in any other settings work alone versus work with a good team? Any- Work alone with your teaching.
When teaching, I work as a team, but I don't know, sometimes it feels like I'm alone.
Yeah, yeah. A lot of it depends on the team. Luckily, in healthcare, we attract good people for the most part, so it's easy to work with. I'm not saying teachers aren't good people, but
Yeah,
some of them you could say like, "Oh God, yeah, yeah." How about you?
So that's why I opened my company, because like I hate working for anybody that's like somewhere between the age of like 40 and 60. They're just like the worst people you could ever meet in your life. But now I work alone.
All right, so some benefits to working
But then on the
alone as
same
well.
hand, like I tried hiring an apprentice who was 18.
Yep.
That was terrible too, because you're just the opposite end of the spectrum.
Yep.
I need somewhere in the middle.
All right, you got to find your people. Hopefully, the rehab world will be your people.
Yeah, I
better. Yeah, good. So anyway, I think there's most people will have better job satisfaction when you work in a cohesive team versus just working by yourself. Um, so the main healthcare settings we're going to talk about: hospitals, skilled nursing facilities, home care, outpatient, and schools. I'm going to talk just broadly about all hospitals. Just realize there are specialty hospitals. Hasbro Hospital is a pediatric hospital. That's a specialty. There's a lot of other specialty type hospitals that I'm not going to go into significantly. I'm just going to kind of clump them all the same. Same thing for skilled nursing facilities. So broad goals for each setting. Hospitals, get out. That's the broad goal of a hospital, to get you out of there. Now, in order to get out of there, you got to be medically stable. But you do not have to function for yourself in order to get out of the hospital. You have to be medically stable. So what the hospital is trying to do is get you medically stable as fast as possible and transition to the next setting. The next setting might be home and it might be a skilled nursing facility. We'll figure that out along the way, but let's get you medically stable first. If you came here because you had a heart attack, let's make sure you're not going to have another one. Stabilize that. Okay, it doesn't matter that you can't get out of bed. At the nursing home, they'll get you out of bed for you. So when we talk about our big outcomes in physical therapy, you guys remember our big 3 outcomes for any patient we ever come across? You guys, way back day 1, we said this. Return to prior level of function is, I think, what we're always thinking about, but there's a lot of others along the way. What are some others? Improve current level of function. There's one other one. Prevent complications down the road. So yeah, great job, everybody. So hospital settings, do they care about prior level of function? I mean, we might care about it to talk to somebody about, but it's not part of our treatment plan, that's for sure, right? Improve current level of function. Yeah, definitely. Because if we improve current level of function as you become medically stable, maybe we can get you home, right? So that's the big goal. And then prevention of the complicating factors down the road is always something we're going to be talking to our patients about. There's never an opportunity to not do that. But really, it's current level of function and where are we going to be next. At the skilled nursing facility, improving function to transition to home safely is the #1 goal. Some people have to live in the facility because it's unsafe for them to return to home. In the home care world, safe functioning within the home. That's our #1 goal. And then transitioning to outpatient when physically able. Now, I will say, most of my patient care at this point in my career is in the home care. I would say 60-ish% of my patients aren't going to transition to outpatient. We just need to function in the home safely, and they're not going to transition to outpatient physical therapy. Getting in and out of the house is too much of a barrier. It's unsafe for them to leave at that frequency. They don't have transportation. we're going to make it function in the home. You haven't left the house. You left the house twice last year. We're not going to make it transition outpatient. You're going to be in the home. We're going to make sure you're safe within the home. Now outpatient. Let's go back to skilled nurse facility and home. So skilled nurse facility, 3 goals: prior level of function, improve current level of function, and prevention of complications. I said prevention of complications. We always do that no matter what the setting. Prior level of function, does it matter at the SNF? Yeah, I think so. And I think really depends on the patient. So the function, right? So if the prior level function is marathon running, does that matter in the SNF? Probably not. Living independently at home without help. Now that's really important, right? So some prior level function can be really important here. Not necessarily work or leisure activities, but activities of daily living, that prior level of function definitely matters. And obviously current level of function. Home, yeah, I think all 3 major goals count for this one as well. But outpatient PT, what's the goal? Optimize movement to improve quality of life. Now we're going to be focused on returning to work, leisure, anything else that we might. So this is where the return to prior level of function is the big focus. That's the first place where that's the huge goal. In schools are a little bit unique. First of all, pediatric population. But the goals for schools is to improve the physical ability to maximize education. So the example is stairs do not have to be part of the plan of care if there's no stairs in the school that they have to navigate around. If they are going to be using the bus to get to and from school, all right, now I can do stairs because they're going to be using the bus to get in and out. So we really have to, just because the patient and their family has stairs at the house and the child might be having trouble with it, if it's not in the school, if it's not education based, we don't put it as part of the plan of care. So there are other settings that we get to work in here, but these are the major ones I wanted to talk about. These are where most of us are going to end up working at least at some point of our careers. One of you may be the PTA for the traveling theater company at some point. But these are the major ones that we'll just narrow it down to for now. All right, so the team at the hospital, biggest, most variety of the team. Who works in a hospital here? I know you do, Jedi. Anybody else work in a hospital right now? So they're going to include physicians, whole lot of types of physicians out there, but their jobs is to order tests, examine, evaluate, and set up the plan for the patient, the overall plan. After looking at the patient, we definitely need PT. We don't need OT. We're going to need speech. The physicians are bringing in people of the team. They're also performing different procedures as well. Then we have the rehab team. That's what we're most familiar with in this room. PT, OT, speech, and recreational therapists are the major ones. PT, gross motor, is a good way of thinking it. I'm going to go into PT versus OT in just a little bit because there's a lot of overlap. But basically, gross motor is a good way to think of it. Lower extremity, I'll get into that in a little bit. OT, fine motor tasks, coordination, upper extremity potentially, and we'll look at that again a little bit. Now, speech language pathologists, speech therapists, speech, swallowing, chewing, and they also do a lot of cognition. So the cognition is looking at those flashcards and identifying the shape or the animal that's drawn. That's part of cognition. So some of my patients have fine speech, but have poor cognition, and we bring in speech therapists to work on that cognition for that recall. And actually, for my speech therapist and my patients, she leaves like, you guys ever see like 3rd grade workbooks? Here's multiplication page, here's the geography page. You know what I'm talking about? They look like that. She got all the grades that, and she just figures out what point is the patient starting at. Okay, these are the pages that I want you to do for homework. Okay, now let's progress through this book. It's very similar to that, and sometimes exactly. So that's where that cognition really helps. Recreational therapists will look at cognition, emotions, planning, all things like that. And I think in the later phase of my career, I might go back to school and become a recreational therapist because they walk around the hospital in some sniffs with Connect Four, deck of cards, whatever board game you can think of, they've got. We want to do hopscotch. That's recreational. Let's do hopscotch. So it's their job is to have fun, and that fun also translates into cognition, planning, strategy, managing emotions when you go down the slide and shoots and ladders, right? So that it's a really, really fun and interesting career. There are not a lot of them around though. So you know, later phase of my career, I'll go back to school to become one, and then it's like, all right, I got to find a job now, and that's going to be really tough because, Rhode Island Hospital has one.
Yep.
Well, the whole lot. How many PTs does the hospital have? I mean, they've got 4 or 5 that cover the inpatient. 4 or 5 different PTs and PTAs that cover the inpatient easily, versus the one rehab recreational therapist. So, yeah.
Why is that only one? I guess it's just not.
A lot of it's insurance driven. And
not needed.
I think the APTA does a great job advertising the importance of physical therapists. I don't think OT, speech language pathologists, or the recreational therapists, professional organizations do as good of a job. I think that's a big part of it. So the American Physical Therapy Association advocates for insurances to pay for physical therapy. We do research all the time pointing out all of the importance of it. I don't think the other professional organizations do as good of a job. I think that's a big piece of it too, if you want to go zoom way back. Plenty of nurses, plenty of different subtypes of nurses too. I don't want to sound ill-informed on the nursing world, although I will if I try to go in deeper on it. Lots of different types of nurses. Lots of monitoring, some procedures, especially when it comes to wound care, sometimes definitely medication management, but lots and lots of monitoring. CNAs, personal care, phlebotomists. Anybody here like needles and blood? And no. All right, so some of you, this wouldn't be a secondary career. I'll tell you what, the best person to be is the person who's really good at blood draws after the person who's not very good at it, right? So someone that's taken 3 or 4 shots and then they say, oh, I got it. And they stroll in and do it right away. Like just needle drop and walk away. Yep. Yeah. Yeah, I think phlebotomists, I'm not sure the exact procedures within hospitals. Nurses can do blood draws too. I'm not sure when they call in the phlebotomist, if it's only with the difficult cases. So anyway, dietitians, housekeeping, social workers. Social workers are really important, especially access to community resources is really important. So when we're trying to get the patient home, and we say, okay, you have a follow-up with the cardiologist because you just had a heart attack in next week, I don't have transportation. All right, well, that social worker will find you a ride because they will eliminate barriers to your care. They will find the community resource that's available to you. I'm always, anytime I talk to a social worker, I'm always amazed the rocks they know how to look under for resources for our patients. It's really incredible. Case managers oversee the entire case. and on and on and on. So there's way more. Actually, respiratory therapist is another one that I wanted to bring up. In hospitals and SNFs, they manage the ventilating systems and equipment for when a patient needs a secondary, a device to breathe for them. My daughter, I told you briefly, my daughter went to the ICU in a little while, about a year and a half ago. Did I tell you that? No. All right. My daughter was very sick. My wife brought her downstairs and she was blue, and it was a horrific event. We went to South County Hospital because it was 10 minutes away from us. Hasbro was full, so they couldn't accept my daughter. And so we had to get airlifted to Yale New Haven, except the helicopter was down, and then it was too windy, and it was just a horrific event. So the ER doc, so this is actually a great example of the healthcare team and when it works well. ER doc tried to intubate my daughter, stick the tube so they can hook her up to the machine to breathe because she couldn't do it for herself. Tried, I think it was 7 tries he took, and he couldn't get it. She try, stats drop, pull out, bag breathe for her, try it again. So by the time, right before, I think it was right before the 7th try, the Yale New Haven transport team walked in, and in walks in this effing rock star of a nurse. She walks in and she says, "Doc, what are you doing? Trying to intubate? How many times have you tried so far?" "Well, this will be the 7th. "All right, Doc, you've tried 7 times and it's not working. What are we going to change?" He says, "Well, she's clamping up every time I come." "All right, sounds like she needs a paralytic. I like this one for pediatrics. And this, how much does she weigh?" "Or she probably needs this dose." Doc goes, "Great." Now, at that point, I mean, it's an emergency. The pharmacists are behind us. They start pulling it together right behind us. So wouldn't you know, it worked. They get her stabilized. Then it took 5 or 6 tries for the respiratory therapist to get her hooked up to the machine because she kept plummeting again, and it was another horrific thing. But we finally got her stabilized so that we could get transported to Yale New Haven. But as we're packing up, I hear the nurse, and now the nurse and that doc have never met each other before. Why would she? She's from Yale. He's here. Just says, "Hey, Doc, I just want to let you know, like, thanks for doing everything." And he goes, and she said something along the lines of, "I hope I wasn't too aggressive," and he goes, "No, you were perfect. Thank you so much. You really came in at the right time." Like, it was just such a nice way to witness communication in a crisis, and then after to say, like, "Hey, thank you so much." Those 2 people, they both hope they never see each other again, right? So it was just really nice to see, like, even in a tense moment, what the healthcare team could be. At Yale New Haven, my spunky little daughter decided to rip out the tube from her mouth at 2 in the morning. Everybody comes rushing in. The respiratory therapist, now she ripped it out, but it was still in her mouth and throat, but it wasn't going into her lungs. So the respiratory therapist gets in there and they go, "Nope, it's out. It's in her, but it's out of the lungs where we need it to be." And then ER doc or the ICU doc comes in and he's watching. He's not saying anything. He's just watching. And she's saying, "Doc, it's out. Like, what are we waiting for? It's out." And he goes, "Yeah. But all he was doing was monitoring her vitals while it was out, because he was just taking that moment to assess, like, all right, well, how's she going to do breathing on her own for a little bit? Because we can in his mind, I'm sure he's like, we can put this thing in any second. Like, let's just see how this goes for a little bit. And she did really well. So they decided to keep it out, pull it all the way out and keep it out. So it was so great because that respiratory therapist was basically saying, "Doc, you don't know what you're talking about. This thing's out." Right? That's communication in a healthcare team in a crisis moment. And he was doing his job. And at the end, they had a conversation where, the ICU doc thanked her for being, so, 1, correct, 2, advocating for the patient. And she said, "Oh, thank you for doing your job." It was just really nice to see that team in another crisis moment work together. So, I hope in our physical therapy careers, we don't have a lot of opportunities to work in a crisis moment like that. But that is what the healthcare team should be working with. We should be working with knowing what everybody's roles are, communicating appropriately, and then listening to one another, and then patting each other on the back and saying, "You did a great job back there," right? So that's how it really should happen, even in
Daughter
tense
okay now?
moments. What's that?
Is your daughter okay now?
She's
You
great,
kinda, like,
thank
left
you.
us for the.
Oh, I have a cliffhanger. Well, you come to class next week and you'll find out more. No, she's great. She got diagnosed with asthma. She just got sick and she had a mucus plug in that blocked one of her lungs. And yeah, it was pretty crazy. Pretty I wouldn't recommend it. Uh, but yeah, she's great now and she's the cutest little thing in the world. So yeah, thank you for asking. All right, so I just want to talk briefly about PT versus OT. Now, this is really broad. The big thing to remember, there's lots of overlap. There are plenty of overlaps. And I have one OT that is out on vacation, and that my PTs are going to have to do a better job. They're going to have to, in a couple of cases, we're going to have to add more visits on the PT side. And that's okay because there's a lot of overlap between our professions. Now, broadly speaking, the PT is going to optimize movement to enhance the human experience, right? That's what we've been saying since day one. We're going to look a lot at gross motor. That's where we're going to lean towards. And we're going to, our basic thought is to improve the person so they can function in the environment. They have stairs at home. Guess what the exercise is going to be? Bunch of stairs, right? They work at a UPS or an Amazon fulfillment factory, and you got to lift boxes off the ground all day. Guess what? You got a bunch of squats reaching down to the ground with something heavy coming to you at part of a rehab, right? We're making that person better so they can function in the environment. Uh, in occupational therapy, first let's define what an occupation is. Now, this is a really cut down definition from what the OTA director. Who's taking class with Christine Lynch? Who's taking Kines online? All right. So when she texted, I said, "Hey, how do you define occupation?" Because I always think it's fun. I always think occupation is work. Occupation in the occupational therapy world is different. So I said, "What's the definition?" And she would probably scold me for cutting it down like this. An occupation is purposeful, meaningful things that people do to occupy their time. Could be work, could be taking care of kids, could be going to school. Anything you spend your time with that's important to you is an occupation. Could be your job, your occupation. So man, it sounds like everything, right? And probably a lot of things to say like human experience, right? So do you see like the level of overlap already? Now they're going to tend to lean towards the fine motor side. Uh, they can also work on coordination and cognition. They're still going to help the person get better, right? They're still going to do strengthening, strength, whatever, how to get that person and improve that person. But they are way better. And I'll say this, and it's not a popular statement, but I'll defend it. They're better at adapting the environment to the person than what we in the physical therapy world are. They can see things differently. They are, in general, more creative and artistic, where in the physical therapy side, we're much more rigid. Again, not always, ton of overlap, but it's a good way to start looking at some of the differences between it. Also, something the occupational therapy world does a lot more focus on is mental health, and I'll talk about that in what CCI does too. Now, I modify my patients' homes all the time. Got to move this chair to over here. We got to move. Let's spin how the dresser is. Let's move the commode over to here. Hey, you need a handrail here. These stairs, we can work hard on it, but you know what? You need a stair lift in order to do this better. I do plenty of home modifications in my job. The OTs just have a bigger bag of tricks for that. Did I show you guys the different utensils, eating utensils once? Did I show you that? No. So here's an easy modification. Large handle spoon. Right. So when somebody has either a hand injury or any sort of problem, this stroke is an easy one where I can't grasp really well. All right, well, make the thing you're grasping bigger, and now you can hold a spoon again. Or this other one. I like these. See these crooked ones? So if we think of like even this larger handle one, it's straight. So in order to get that spoon to my mouth, I still need to like it's called radial deviation. I need to manipulate my wrist in order to get that food to my mouth. Where these here are already curved, I can keep my hand straight and still get food to my mouth. So in my physical therapy world, I have a tough time thinking, oh, do we need just the big handle or do we need the crooked hand? Like I have a hard time with that. The OTs do a great job. You know what one of my other favorite devices are? Who has trouble buttoning their buttons? Anybody ever try to like button their buttons after their elbow fell asleep, after they leaned on their elbow and their hand fell asleep? Really tough. So this here for people again with that fine motor deficit, you grab this large handle here, you feed it through the hole of the shirt, you grab the button, you pull it through, then you unhook it and you're ready to go. That's a cool one. Sock aid tools. Could be because we can't reach down to our feet to put on the footwear, or it's just really hard to like manipulate the sock and put it on. So there's a tool that we get to use there. So I will say there's plenty of times, again, I modify the environment to help my patient all the time. There are plenty of times I ask my OTs, I need help. I got this person with this problem. This is where their setup is, and I can't figure out how to do it. And they got something in their bag. Oh, you should just grab this. Jeez, I didn't realize it was that simple, right? So they're way better at adapting the environment to the patient. Now, I will say gross motor, fine motor, the previous slide, we said lower extremity and upper extremity. So that's an insurance thing. That's not a profession thing. So in the hospitals, home care, nursing homes, even outpatients sometimes, PT and OT can't bill for the same problem. So if my patient needs to get in and out of their tub, step up and over, get in, and I'm working on that, OT can't work on that as well. Because we're both doing the same thing, and insurance says, why are you double billing me, right? So here's how the general breakdown of PTOT and speech can work. PT, our job is to get the patient to the kitchen, grab their food, carry it to the table, and be able to sit down in the chair appropriately. OT's job is to make sure the arm and their hand can get food to their mouth with tools, with whatever, however they can modify the environment to get it to their mouth. And then speech comes in and helps that patient chew and swallow safely. That's how it all works. In and out of the shower, PT's got in and out of the shower. OT, you figure out what to do once you're in there. How do they know which lever is hot water versus cold water? Do they know how to sequence, shampoo, then conditioner, or, all of the cognition that goes along with that, all of the reaching that goes along with that. So there's a ton of overlap. Now, if no PT is on the case, can OT get the help to teach the patient how to get in and out of the shower safely? Yeah, absolutely. If there's no OT, can I work on the patient's shoulder to make sure that they have enough range of motion to get food to their mouth? Yeah, absolutely. Might not do as good of a job ordering the right adaptive equipment, but I also know who to ask for help when I can do that. So there is a lot of overlap between our professions. Just quickly, PTA program versus OTA here at CCRI. I also want to mention massage too. PTA program, 2-year program. We have 24 seats. OTA has 24 seats as well, but it's an 18-month program. They have a little bit more prereqs to do than in the PT side. PT side, we have application in February. How many people are applying this February? How many know they're going to finish up their prereqs and apply next year? Yeah, good. The application is based on points. Did anybody look at that already, especially the people that are applying this February? So, you know, you get points for your grade in this class. What are the big 3 classes? This class, anatomy, and med term, I think, are the big 3 that you get additional points for. And then your overall GPA also gives you points. Also, there's the AccuPlacer test. You guys saw that. If you have to score high enough to get points on that. If you have an undergrad degree, you get to not take that test. You just get full points for that test. So that's pretty good. And there's some other things here and there, but however many people apply, top 24 students with points gets in. It's pretty cut and dry. From my side, I love how simple the process is. From this, if I was the student, I'd say, yeah, I just missed out, but I'd be even better than the nerd that got the good grades, you know. But from the other side, it's pretty good.
How many people usually apply? Like if there's 24 seats to like 50 apply?
Some years more people apply to the PTA program than the DPT program at URI. That's why sometimes they say it's harder to get into it, the PTA program than the URI DPT program. That's not really true, but I mean, in terms of applications and acceptance rates, I guess you got a point, but there's a couple more hoops to jump through on the other side. So I don't know the answer to that. So give me 1 second. Let me just finish this up and then I'll get to you. So OTA program, 18-month program. They have 2 application periods, February and spring. It's also based on points as well, and the top students get in. But one other unique thing about the OTA program, the students also graduate with a certificate in mental health first aid, which is a unique characteristic. And I'm not exactly sure what you would be able to do with that, but I love how it's in our PT world, we're much more rigid. This knee, this anatomy, this exercise, it's very rigid. And with OT, it's just a lot more broad. And I think that's really helpful for our patients too. So I'm going to press pause, turning back. CCRI also has a massage therapy program. So who's waiting a year to get into the program? I will say the massage therapy program, it's a certificate program and it's September to August. It's not full 1 year. And they do a great job. And some of the courses, the pathophysiology course in particular, you would take in that massage program and you wouldn't have to take it once you got into the PTA program. So some of the courses are you would be able to take. So the pathophysiology course, it's in both curriculums. So if you already took it when you got your massage certificate, next year you get into PTA, you don't have to take that course. You just took it. So there's a benefit too. I will also say, and I'll say this with it being recorded, I think massage therapy is a perfect part-time job. I think it is a really difficult full-time career type job because 1, you beat up your own body so much. 2, how many personal trainers do we have here? Oh, Victor, you too. Tell me the day in the life of the personal trainer.
What part?
I want to know working hours because I already know them.
Working hours?
Yeah.
So, I mean, you have that split in the middle of the day. You usually start 6, maybe 5 in the morning. You work it so around noon, then you get a break, about like 3, maybe 4 hours, depending if you could get like those afternoon.
Right.
Mothers. And
Yeah,
stuff like
yeah.
that. And then you go right back right around 4, 5 until like 10. I would.
So it's exactly, I mean, I know it. Working as a personal trainer, you work from 5 a.m. to 10 p.m. to do an 8-hour day.
Yeah.
It's a really long day, and in the middle of the day, you got do whatever you want, but that's a tough thing to
It goes
swing.
by like this, like those 3-4 hours that you get off.
Yeah.
you kind of
Yeah, I
have-
mean, basically, you're working a 15-hour day, but only getting paid for 8 of them. That's basically what it is. It's really tough career.
Mhm.
Perfect part-time job.
Yeah.
Perfect add-on to a different stable career. So I really think PTA or OTA combined with massage, I think is a way you make a lot of money because I mean, you can charge over $100 an hour as a massage therapist, and I know my wife will gladly pay it. Uh, I mean, you'd work a half a day on a Saturday, and you got your car payment for the month. But I think it's really tough to do full time. And I think most personal trainers would also agree with us, right?
Yeah.
I don't think I'm speaking out of turn when I say that about massage therapists. I think most massage therapists would agree, with some exceptions here and there. I will also say about massage, some hospitals also hire massage therapists to work at the hospital for patients and staff. So that's pretty cool too. So in those kind of scenarios, maybe it's a better work-life balance. Some corporate events too. Yeah. Anyway. We have a lot of PTAs that come back and do the massage program because I think it strengthens your PT work as well, having better hands-on skills. And I also think it's just a way you get to make a lot more money with yourself. So, all right. I can't believe we're only on skilled nursing facility. Jeez, I remember what I said about rambling today. I think that was it. So skilled nursing facility, slightly smaller than the hospital. The big difference in staff is physicians are not required to be on site. Physicians are going to come in and out, but they're not required to be there. Hospitals, there's a physician 100% of the time there. So that's the big thing. So, and the amount of variety of staff is going to depend on the size of the facility and if they're a specialty or not. But PTs, OTs, speech, nursing, definitely, CNA, social workers, housekeeping, others on and on. Recreational could be respiratory therapists. I have a friend that works in Coventry. She's got respiratory therapists on her staff. Not all of them do. That's part of the specialty of her place versus others. I don't think I said how communication happens in the hospital. Communication hospitals, the biggest thing is the daily rounds. Physician team comes around and goes around and talks to every single patient, reviews the case and sets up, make sure the plan of the day is good, any adjustments there. Other communication, electronic and case meetings. Electronic communication we'll talk a little bit about later, I think. So in skilled nurse facilities, rounds can occur, not always, but they can. Definitely case conferences. Every single Monday we meet 8 a.m. We talk as a team about all the cases. Electronic messages, and what I think happens more in skilled nurse facilities versus hospitals is the informal communication, the lunchroom, the water cooler, the hanging out at the nurse's station. I think that happens less in hospitals just because of how big they are, versus the skilled nurse facility. There's 2 floors, 1 floor, maybe 3 floors. It's a lot smaller of a place where you get to bump into people. Hospitals, big hospitals, it's hard to bump into people. There's many different break rooms, not just the break room, that's where the informal conversation happens. And that's what I mean by saying, like, hey, I got this trouble with the patient. I can't figure out. Are you seeing them too? No. What do you think? And let me just bounce this idea off. That's what I mean about the informal communication. Home care, smaller than SNFs. Some home care agencies have skilled nursing. Social workers, others don't. The minimum member of the team, skilled nursing, CNAs, PTs, OTs, speech, and case managers. That's the minimum that it would be. Might be some others, might not be, depending on the home care agency. Communication occurs directly. Case conferences are the big one. For my company, we do it every other week. Other companies do it every single week. Informal meetings are less common because I need to bump into the person. Like we're all working and driving in our cars. It's less likely that we're gonna bump into each other. It does happen, but it's not very common. Team and outpatient, smallest and most specific team, usually PTs and PTAs, maybe some techs, care coordinators, billing department. I will say care coordinators and billing department, that happens in all the other settings as well. Occasionally OT might also be in the same practice, maybe personal trainers, maybe nutritionists. I have a friend that also has a mental health counselor, a psychologist that works at his outpatient practice. So, you know, there are a variety of different setups, but you know, mostly it's just the PT side. Sometimes it includes more. Direct, informal, and most importantly, with documentation, all of these should happen. Now, in schools, the most unique aspect of schools is we have non-healthcare workers that are on this team. Teachers, teachers' aides, principals, families, 100% families are part of the team no matter what. But something about kids is, and pediatrics is, the patient is who you're working with, but it's the families that you have to consider mostly. That's the bigger wild card. You know, we'll talk about pediatrics next week. Any therapist will be able to work with a kid with Down syndrome. It's the family of the kid with the Down syndrome that's going to have the bigger impact as to what happens. So, you know, families have to be at a higher priority than other places. And I will also say about communication with non-healthcare workers is we are going to have to translate for our non-healthcare workers a lot. And we're going to have to have them translate the education side to us a lot too. But it's a really interesting case. Have you run across, do you even have PT at your school? I know public schools, we have to have it.
They don't have that.
Okay.
They have a gym teacher.
Right.
Instead.
Yeah.
But she's pretty knowledgeable. She does
Oh, I'm
some things
sure.
that I haven't seen in like regular schools.
Yeah.
too.
Yeah, I'm sure.
Cognitive thing and balance stuff. Like,
Yeah.
they usually do like regular stuff at schools.
Yeah.
That would be pretty impressive.
Yeah.
A little bit more. Than
Tell her
I
that.
think. Oh,
Tell her that. It's always nice to get a compliment. That's an important one. So, all right. So we already know about the T models homework. Due next week. Create a brochure of profession other than physical therapy or occupational therapy. Whether it's flyer style or brochure style with the 6 panels, I don't really care. You design it however you want. Make it nice. So kind of think of it as like you're going to drop off flyers for high school seniors that don't know, you know, I want 10 different healthcare flyers to look at, which should I start looking into more now. You have all the information to look at, upload to discussion board. And in that discussion board, I have the instructions, but also all of the CCRI programs that are healthcare focused, I put in there as well. So you can link right to that if you want.
What's the homework that you told us to do?
That we did weeks ago. Yeah, I told you about it weeks ago when we didn't have class that one time.
I submitted.
It's due on the 7th. If you already submitted it, I haven't graded it yet, but you're fine. Yeah. I do suggest looking at other people's projects. Pretty cool. All right, so current issues within physical therapy. First thing is the multi-state licensure. This is one of the bigger burdens for all healthcare workers, and that burden was a huge problem during COVID when nobody could find workers. So the problem is each state you need to get a license to work in that state. Makes it really tough if I move. It makes it really tough if I'm a travel therapist where I only have 13-week contracts you know, I'm moving all around the country. And it really is tough for states like ours, not a whole lot of states like Rhode Island, but border towns. I've got students that live in Westerly and Fall River and Attleboro, where I want a job, but I gotta in order to look for a new job, I gotta apply for this license just because the closest place to me is actually in Connecticut, even though I live in Rhode Island, like they've got to decide where to work. Uh, it for states like ours, it's a real burden, and some border towns could be that way too. So what happened is a bunch of people got together and decided to say, okay, we want to improve this. And they made the PT Compact. PT Compact is a way that we get to have one license, and that's going to carry over through different parts of the country with some exceptions and some steps we still have to jump through, but it makes ease of travel way better. Um, Big benefit for us as practitioners, as well as travel PTs and PTAs. Also, it makes it really helpful in times of crisis, like during COVID, to help the public and make sure that there's better access to care across the country. So here's what the map looks like. In dark blue is all states that currently have PT Compact. States in light blue have the laws have been passed, but they haven't started. I think January 1, all of these states will turn to dark blue. That and in green, which Rhode Island's part of it, the legislation is introduced. We'll have to continue to fight the fight, say it's a good idea, but the trends are looking really good. And when I started teaching this a few years ago, it was really just the middle of the country was part of the compact, and it's exploded in the last 3 years, which has been great to see. Now there's a few rules there's rules to everything. Rules are you have to declare a home state. And then if I want to go to a different state, I have to make sure I pass their state licensure test, which is usually a 10 to 30 question test about just their state laws. Can you do spinal manipulations, wound debridement with sharps, all of the other things we've talked some about. So you just have to know the laws of that state. That's typically the other hoop. So that's a great thing, and I hope that Rhode Island's close to passing it. In Rhode Island, physical therapists can now order imaging for their patients, and that's going to really help with direct access, and so it's going to help patient care. So research showed that physical therapists can safely and effectively order X-rays. Enhances our ability to practice and direct access. Also contributes towards reduced healthcare utilization and cost. When you go to your primary care physician because your knee hurts, the first thing they're going to do is order an X-ray. They don't even have to think like it. They don't. It's just get an X-ray. We'll start looking from there. That's their starting point. We in the physical therapy world, that's not our starting point. We don't want our patients to get X-rays when they don't have to. And especially because we don't want our patients to get afraid of the things that it shows. I've got early signs of osteoarthritis. How many patients have heard, how many people have heard patients say they get the word like, oh, you have a little bit of arthritis on the knee, and they freak out. I had one lady, she was, how old is she? She was in her late 80s. Her knee hurt. She went to the docs, got an X-ray. And she was devastated. I came to her house shortly after, devastated. Josh, doctor told me I had arthritis. And I looked at her and I said, of course you're 88. Of course you have arthritis. Like that. You didn't need an X-ray to know that. She was, what? Like, you've had X-ray you have arthritis for years. Like, that's not why your knee hurts. So we're going to get your knee better. You're fine. Like, your knee hurt a week ago. We're going to get you feel like you did 2 weeks ago. Like, stop freaking out, right? So, but that happens. Our patients become married to what the imaging says. So we should be really careful in just ordering imaging when we don't need it. Improve rehab outcomes. And the other thing that we have to do, the nationwide physician shortage, which is going to continue to grow, and all members of the healthcare team should be practicing at the top of their practice and not being afraid to do that. So it's going to decrease some of the burden of the physician shortages as well. Telehealth. Telehealth is tricky. It's exploded in the last 3 years, which is good. But in the cross PT, it can be challenging. So virtual patient visits, we're used to interacting in person. We're used to touching the thing that hurts and say, is it here? Is it here? We're used to that level of knowledge. We're used to doing exercise, be able to touch the patient, say, no, up like this, no, down like that. Like we're used to being able to be in contact with our patient to do it. So some patients might have, PTs might have trouble adapting to this form of treatment. Uh, Maybe it's because they lack training. Maybe it's because they lack experience. Maybe the patient's technology isn't good. How many people have taken online class and their camera stopped working? Actually, in my class, the microphone stopped working on one of our recordings, right?
Yeah.
So, okay, well, that's a barrier, right? And that's not something everybody's comfortable troubleshooting. Uh, there's also a worry that, well, if I'm not there, the patient might hurt themselves doing the exercise I told them to do. Maybe that's true. But I think for some patients, it's probably really good for, and others, it's probably not so. Uh, Especially the specialty therapists. I think it would be really great to be able to practice across in a virtual fashion, whether it's collaboration or directly. Uh, it's improving, but finding a woman's health physical therapist is tough. But if we could say, if that women's health therapist could also treat 3 patients at her house, making a little extra money and do it all at the seat of her couch, that might be a little bit easier to do that. Also, it reduces cancel and no-show rates. So it could be used either directly, our whole treatments are telehealth, or it could just be, hey, it's snowing today. Why don't we do this virtually instead of coming to the clinic? Oh, instead of canceling, how about you do it at home? You got a camera? Perfect. Let's do it there. That's going to decrease our no-show rate, improve patient compliance, improve their progression through their plan of care. So also from us, work from home options. I have a friend, he's in IT, he works from home for 4 different companies all at the same time. He has 4 full-time jobs, he has 4 screens, he is working full time for 4 different places at once. I say, that is crazy. He goes, yeah, it's easy. If there's ever a problem, they just think I'm working on it. Like, and I am. It's just I got to do this one first. Like, it's no different than if I was in the office. Uh, we don't really have a lot of work from home opportunities from in the physical therapy world, and I think that would be a nice option to have. I think that potentially. Potentially also treating patients across state lines, especially when you're the specialty therapist. I think that can have a huge impact on our patients' access to care. Education cost is a huge problem in the physical therapy field. Uh, we need more and more physical therapists. There's a physical therapist shortage. And there's a lot of schools, but the big problem with it is they're really expensive. Average debt for physical therapy graduates is around $116,000 of education debt. Nearly 3 times the national average of $40,000 a year. So it is very expensive. Now, the Physical Therapy Association is looking at ways to reduce that burden. There are some improvements on legislation to say, if you work in healthcare, maybe some of these loans can be forgiven, at least a percentage of it. But it's really, really tough. But that's also really good for physical therapist assistants. If there's not enough physical therapists out there, PTAs can fill in a lot of that gap. And my PTAs that are graduating are not having any trouble finding jobs. In fact, they're usually getting multiple job offers, and they increase their pay because they say, well, this other place offered me this. So it is a great time to be a PT or a PTA. I just wanted to compare debt from URI, grad school only, not including undergrad. It costs between $70,000 and $115,000 to graduate from URI. That $40,000 swing is because of, well, where do you going to live? Do you have to travel expenses? There's a lot of other costs there, but it's at least 70 grand. If you're going to live at home and walk to school, it's 70 grand. Average PT salary, 89 grand. Pretty good. PTA program, start to finish, from your day one on campus, goes straight through, $17,000. Now, that's not free, but compared to 70, that's pretty good. Average salary for the PTA is somewhere around $59,000. So yes, you get paid a lot more as a PT, but I will tell you, the loans come due. That pay difference gets sucked up a lot in paying back those loans. So I will also say for the PTs that have a high debt, they chase the highest paying jobs because they have debt to pay. The highest paying jobs are typically not the best jobs to work in, which leads to more burnout, leaving the field, creating a bigger hole. Now we need more and more therapists. So it is a vicious spiral that our current graduates are going through more today than at any other point in the history of physical therapy education. But that makes PTA a really great option. I've had a couple of PTAs get paid over 60 grand for their first job and expect to go higher from there. So I would say 17 grand versus 60, not a bad debt to income ratio at all. Adapting to new technologies. We talked a little bit about that with the telehealth, but that's part of it. Virtual reality for treatment and evaluation, pretty cool. Using wearable technology, smartwatches, other sensors. I was just at a conference, guy talked about wearing smart gloves and sensors on their footwear and having the patient do a bunch of tests, and that data comes to me in my office. I don't have to be at the patient's house to do an evaluation. They just have to wear these sensors to get this data. So some really cool stuff, some flaws with it, but some really cool stuff that we could start to work on. The other one that is, anybody use AI for their writing assignments yet? Oh, you should definitely look into it. I'm using it. I use AI for documentation, and then I'll go on a little tangent. AI for documentation is our insurances are already using AI to find our errors. So we will need to start using AI to do our documentation because it's just our arms race. So
that doesn't violate like HIPAA.
Well, that's good. That's a very interesting question. Does AI violate HIPAA? It depends on what the information I give AI to use. I actually, it's between us, I used AI to write up one of my more extensive patients the other day, but I took out his name. I left in diagnosis because without the name, there's no other PMI to attach it to. It's just somebody with this injury. So I did. Yeah, as long as we're not giving the PMI, the protected medical information, we can be okay. But at some point, there will be AI for documentation that is HIPAA compliant at some point. So being able to use AI, I think, is going to be an important tool. In fact, in one of my classes next semester, we used to have this big writing project, and I'm going to keep it, but I'm going to make the students use AI to do it because I think this is going to happen in the next 3 years, which in healthcare is lightning fast. For AI, it's behind the ball quite a bit. I suggest everybody, ChatGPT is free. I suggest everybody sign up for it. Start playing with it. The more I use it, the more I see ways to use it. How many of you, your other teachers, think it's cheating? Yeah, that's ridiculous. Tell them to call me. It's ridiculous. Because they can use AI to grade your writing assignments, just like, yeah, if they're not, they're being really dumb. Anyway, if you don't want to use it academically, that is okay. Like, you listen, if your teacher says it's cheating, then don't use it. Come to me and we'll talk about what it really is. But I use it. Who does their meal planning in the house? For me, every Sunday I wake up, I sit down. What are we going to eat for the week? Make my grocery list. Anybody do that? Right. So the other day I used ChatGPT. I looked at what was on sale, the flyers. I said, okay, these 4 things are on sale. Give me 3 options for dinner for each of them. Okay, I don't like those. Give me 3 more options, but make sure it takes less than 30 minutes each to cook. I like those. Okay, here's my 5 dinners I'm gonna make. Make me a grocery list, but make sure you put it in the order of produce, meats, pantry, seafood, and frozen. And then that's all done. 15 minutes. I'm telling you, it's pretty great. Did you have something?
I use it to prescribe like exercises for people. I'm like, oh, my legs bigger, but I don't really feel any no pain. You that you're not moving.
Yeah,
Just
yeah,
get
yeah. How fast is it for?
as fast as you can do.
Yeah, yeah, yeah. I suggest everybody play around with it, whether it's for your personal life or for your schooling. Listen to the other instructors on what is, but it's. I haven't figured out how to get it to grade your homework that is due next week. I'm gonna work on that though. No, I am. I'm gonna work on that. So it's coming. And you should definitely use it. Now all of these new technologies will improve access to care, which is ultimately what we want for the public, right? Better care to medicine is good for the public. Hopefully it can decrease documentation burden, and I would love for that to be the case. It takes me 2 hours to document a brand new patient, that we call it a start of care in home care. It takes me 2 hours to document that. If I had ChatGPT do it, how fast do you think it would take? It would take maybe 30 seconds for it to do. So if we could decrease that burden, I get to see more patients. Wouldn't that be nice? Instead of typing on a computer, I get to see more patients, right? Performance evaluations and treatments in dynamic ways. It could be really wide open. Other ways to improve access to care, improving direct access, not only the laws of direct access, can you do it or not, but making sure insurances pay for direct access. That's the other barrier we've got to take. Improving insurance coverage, authorization, capitation, reimbursement. One of the other things about that some insurances used to do is they would say, oh, physical therapist, some of you guys wanted to be specialists. Guess what? You guys ever look at your insurance cards and it says like primary $10, specialist 100? I don't know what the exact numbers are. You ever see that? So they said, no, physical therapy, you're a specialist. They have to pay $100 to see you. But they're going to see me 3 times a week for a couple of weeks and 2 times a week for a few weeks and maybe just what, like, you're going to see me 12 times in the next 2 months. It's $1,200. I'm not charging them $1,200. No, it's the $10 one. Do the $10 one, because a specialist, the neurologist, the cardiac, you're going to see them once a year. You're not seeing me once a year, right? So, that kind of stuff, and giving some legislation to make it fair. Well, what is the fair copay that it should be? But more access to care means more work for us, which is great. Maybe higher pay. I don't know, but it'd be nice. Something to dream of. All right, so that's it for that. Do we have any questions about team models or current issues? All right, we will end this.